Thank you very much, everyone, for joining me today. My name is Dr. Mahin Ashraf. I am from Bangladesh. And welcome to our imaging study weekly ultrasound case discussion session. We run this session for last few months, and we got a lot of participants interested this session to be continued. Anyway, if you are new to our this program, we have a YouTube channel named Imaging Study, which already has crossed 63K subscribers. Thank you for being with us for this long period of time. And we have already uploaded 477 videos. Not all the videos are of ultrasound related topic, but yeah, we have got 477 videos on our YouTube channel. And if you have missed our previous sessions, we have already uploaded those sessions on our YouTube channel. So you can just go there and get them free of cost, obviously. If you are from my local country, we have stopped our regular paid sessions till I think mid-April. So due to the month of Ramadan, and after the Eid break, we'll come back again with our regular sessions. So till then, we'll continue our free sessions on every Friday. So if you are interested, you can just join us on every Friday at 10 p.m. in our local time. Just add GMT +6 time, 10 p.m. So we have already given you the time schedule from your country. So you just can check them on our post. Anyway, let's join our first session today. Today we'll discuss, as like before, we'll discuss 5 cases, and hopefully some of them may be helpful for you. So let's start with the first case. So this will be a 67-year-old male patient who came with left-sided hemiscrotal painful swelling. There was no history of fever. We expected some fever. So when there is a severe painful swelling of unilateral scrotum, then we actually think about 2 cases, commonly 2 differentials come. The first one is the testicular torsion, and the second one is the epididymo-orchitis or epididymitis, whatever. So the inflammation or torsion, these 2 are the common differentials, and we kept torsion as the first differential because it seeks medical attention, actually. So surgical correction may be required. But for the epididymo-orchitis, we commonly face these inflammatory cases more than the torsion cases. So anyway, let's see what we have got in this patient. So here's the picture. We have measured the testis. You can see this is the right testis. It looks quite normal, except for some collection adjacent to it. This one is the left testis. It measures slightly lower than the right one. So you can't say it as a swollen testis, but you can see some unusual structures within this testis. You see these heterogeneous areas within the testis, which took our attention because patient is of 67-year-old. So we don't want to end the diagnosis only by telling it as an inflammatory condition. There should be something else going on here. So let's see what we have got on ultrasound. So we also checked the scrotal cavity that showed mild to moderate hydrocele bilaterally. So this is the right side. You can see the fluid, and this is the left side, which showed a little more fluid than the right side. So let's jump into the real-time imaging, and now you can see this is the left testis and hemiscrotum. You can see this is the epididymis here, and yeah, there is a fluid collection here. The main thing that we want to notice here is the parenchyma. You see the parenchyma shows some heterogeneous space-occupying lesion or something like that. So there are some mass-like areas, but it appears to be slightly cystic. So what can it be? So it might be the malignant lesions, benign lesions. It can be necrotic lesions. So whenever you see a case of acute epididymo-orchitis, make sure you need to search for necrotic spaces. Especially we commonly see that in the epididymal region, like epididymal abscess or something like that. But we commonly ignore the testis. It may also show some necrotic spaces inside. So Is that a necrotic space, or it might be a malignant lesion also? So how can you differentiate? It's quite easy. Just put the Doppler. Usually testicular malignant lesions show high vascularity. And obviously, if it is a necrotic lesion, then you won't see any vascularity. So we want to put some Doppler and want to differentiate between these two. So let's see the picture. So you can see these are the area of interest for us. Everything depends on the Doppler. We also checked surrounding areas, like on the left epididymal head, we found a tiny cystic area here. This is a very tiny cyst, but it's very common findings during our scrotal ultrasound practice. So very tiny cystic structure, ignore this structure. So now we have put some Doppler. In our regular setting, we with same PRF, same color gain setting, you can compare the vascularity between these two testes. So this is the right one, which is showing irregular normal flow. But in comparison to the right one, if we look at the abnormal left testis, now you can see it is showing some increased vascularity. Again, the parenchyma is slightly darker than the right one here on the left side. So definitely the patient is having inflammatory changes within this testis. So let's see on real time. Now you can see a good amount of vascularity on the left testis. But if you look at these areas, you can see there is no vascularity inside. Even there is no prominent peripheral vascularity also. If it was a lesion, neoplastic lesion, then there should be some vascularity. There should be some neovascularization or whatever. But we can see there is these are the normal vascular flow pattern of the testis with increased flow due to the inflammation, but there is no disorganized flow due to these lesions. So these are quite avascular spaces. Now let's look at the epididymis with color flow. Now you can see crazy vascularity within the epididymis and obviously in the testes. So this indicates this is a case of acute epididymo-orchitis. Now what about these areas? These areas are the necrotic spaces. So if you give this patient without any treatment, then it will turn into an abscess with the regular abscess features. So these are necrosis of the testis during an inflammatory process. So here's the picture. You can see there is no vascularity within these necrotic spaces. And if you check the vascularity, we have just took a sample from the epididymal artery, not the testicular artery. So this is the branch of testicular artery. And here you can see a good amount of diastolic flow with reduced resistive index, which is due to the inflammatory process. So here is another picture. We have measured the largest necrotic space. This may not be any important finding. Just we did it as a routine procedure. Okay, so here is the vascularity of the testis and epididymis due to acute epididymo-orchitis. Now, if I ask you about the vascularity, are you satisfied with this vascularity? Like, is it okay to say the increase of vascularity for the testis especially? Yeah, for the epididymis, it's okay. It's a quite good vascularity here. But for the testis, is it okay? So usually in your machine setup, there are some different presets. You have to understand in which preset you may see the best vascularity in case of torsion or in case of high vascularity states. So it will help you to understand the situation. In my machine, this is a Volution E10 from G Healthcare. So G is not sponsoring this video. This is very bad. So in my machine, I have seen that whenever I want to see the vascularity with similar preset, similar PRF adjustment, if you go to the muscular setup or MSK presets, you can see very good vascularity. Like, let's see this case with the MSK setup of this machine. This is the small part setup. This is my own preset. So I adjusted it for regular testis ultrasound practice. But let's go to the manufacturer's preset. for the musculoskeletal ultrasound. So let's go there. You'll see some good detail here. Now you see there, this is the normal PRF, but the other measurements are quite, or other presets are quite different. Now you see the vascularity of this testis, it's crazy high vascular, but still, if you look at these spaces, the necrotic spaces are showing no vascularity, which indicates this is definitely some necrotic spaces or avascular spaces within an inflammatory testis. Now, what about the epididymis? Epididymis should also show the vascularity. So you see, this is the epididymis, which is showing also the crazy high vascularity. So definitely this is a case of acute epididymo-orchitis. So whenever I face confusion with torsion cases, I usually go to the musculoskeletal preset in my machine. It may differ from machine to machine, but for my machine, I saw that the musculoskeletal preset gives me the very best vascularity. Okay, so manufacturers, please put this amount of vascularity in other presets also. So anyway, here is the picture of the left testis and the epididymis, which are showing very good vascularity. So we have put some 3D, obviously, and on 3D ultrasound, now you can see high vascularity within the testis with good amount of flow. You know, we have taken it with our regular curvilinear volumetric probe. So the resolution may not be as good as you have seen on the linear probe setting, but still it's very good to understand high vascularity within the testis. So we have just adjusted and rendered the image like this. So in near future, all these cases will be shown on 3D like this, hopefully. So this is a case of left-sided acute epididymo-orchitis with the testicular necrotic spaces. So there is also bilateral mild hydrocele and left epididymal tiny cyst. So anyway, let's jump into the second case. But before that, please, whoever got connected to us from Facebook or YouTube or wherever, don't forget to mention from where you are getting connected to us, like from many different countries. We have seen your previous comments, like you have joined to this program from very different parts of the world. Like in some situation, I have found some countries I even have never heard of those countries. Like I have found one or two countries. I'm not very bad on remembering the names of countries, but still I have found one or two countries about whom I have never actually heard of. So don't forget to mention about that. Okay, so let's jump into the case number 2. This is a 32-year-old male patient. This is an interesting case. The patient came with a history of arteriovenous malformation on in his left forearm region. So he went for a surgical procedure to remove this AVM around 6 months ago. And now the patient came to me. I can still see the scar mark over the forearm. And patient now came with again the swelling over the forearm. You know, whenever you do an AVM surgery, there is always a risk of reappearing of AVM, and that will be very crazy AVM now. So let's see what we have got on ultrasound now. So this will be a high frequency ultrasound of the forearm of this patient. So when we put the ultrasound, now you can see some cystic spaces, heterogeneous echogenic area. It goes up to the muscular layer, invading the muscles, and you can see some cystic spaces inside. So these are actually the venous channels, and you should find some arterial channels also. So we need to put some Doppler, obviously. So let's see it from different angle. Now here you can see it is involving also or invading the muscular layer of the forearm. So this is the posteromedial aspect. So at this part, this is the area. This is the area posteromedial aspect. So here all the parts are filled with this type of vascular channels, and we are searching for a definite point here. I think it's not seen here. So let's jump into another view. Yeah, here you can see we have changed my preset to the musculoskeletal one. Now you can see this spaces quite well. So using different presets will help you understand the pathology quite clearly. You see some spaces. Let me freeze the image at this point. You see this flow. This is called the rouleau formation, or we call it the venostasis. So this is the venous channel having the stasis flow, so or non-spontaneous flow. So usually if you put Doppler, you won't see any flow through these vessels. You need to compress, then you will see the flow. Okay, but here we have seen an important finding. Just let me go a little. Yeah, here you can see this structure. This is a calcified structure, casting posterior acoustic shadow. There is a fine posterior acoustic shadow over here. So this is called the phlebolith. So this is the phlebolith, which indicates this is definitely a vascular malformation here. Okay, so we have got a very important finding here, that is the phlebolith, and this whole structure, there is another phlebolith here at this point. So this whole structure is a vascular malformation. Now we want to differentiate it, whether it's a venous channel, venous malformation, is it a hemangioma, or it is an arteriovenous malformation. Now we need to solve it. So let's see it from different angle again. Now you can see all these venous channels through this foramen and throughout the foramen and forearm, and it's almost occupying whole of the forearm. Like it will be very difficult to solve this case for the vascular surgeons, I think. Okay, so let's jump into the picture. I have taken a panoramic shot, not a very good one, but still throughout the forearm, you can see at the posteromedial aspect, this lesion actually is present. So here's another picture. You can see this is the phlebolith, which is an important finding. Whenever you see a vascular malformation, try to search for a phlebolith, because when we do the CT or we do the X-ray, we usually get these phleboliths, and they're very important feature of the vascular malformation. Within the venous channels, you will see calcified areas. So again, another panoramic shot, and now you can see this large area throughout the muscular channels, muscular layer, this whole vascular malformation. Now let's put some Doppler. Okay, on Doppler, I'm just compressing. When I'm trying to compress, you'll see the flow. You see there are some arterial pulsations, but venous channels are not showing flow. But when I compressed, you can see the flow. So just after compression, you will see the flow. This is the principle. I'm just doing nothing, just putting the transducer here and just pressing it ups and downs, and you can see the flow through the venous channels during the compression. So it indicates that these are the venous channels, predominantly venous channels, but you can still see prominent arterial flow also. So we have got arterial flow, we have got venous flow. In normal cases, you will see a feeding artery, you will see a draining vein, but as this is a post-surgical case, in this situation, surrounding vascular channels will get aggressively toxic, and they will supply this lesion through many different channels. So it will be very difficult for ultrasound to say that the lesion is getting supply from a single artery or draining through a single vein. Rather, you will find multiple draining veins, multiple feeding arteries in this type of cases. So better to go with a CT angio or MRI evaluation. So here's the picture. Now you can see on the left side, during no compression, you are seeing only the arterial vessel, arterial structures, which were pulsating. We have seen before. And now during compression, the venous channels are also showing flow. So these are the non-spontaneous flow. That's why when you are compressing, they're showing the flow. So we have taken sample from the arterial section. You can see these are the venous flow on the opposite side of the baseline, and above the baseline, you can see the arterial flow with a good amount of monophasic flow pattern, and the resistive index was 0.72. So these are all the supplying arteries. So it should be okay if I end this case at this point, but unfortunately I can't. Let's see another view. Now I'm going forward to the hand of this patient. I want to see the end of this lesion. But when I'm trying to go just at the wrist region or dorsum of the hand, I can still see these vascular structures at the dorsum of the hand. So that means that this lesion is extending up to the hand. And let's see on the next image. So here I have just crossed the forearm, and now I came to the hand. I still can see this venous or vascular channels within the hand region. So this is the dorsum of the hand, and when we put the Doppler, we still can see the flow. Even these venous channels are obviously getting connected to the palmar or dorsal venous arches. So it's a crazy situation, to solve this patient. Okay, so you see, they are just going deeper at the wrist region or up after the wrist region, at the hand region, they're going very deeper. So obviously, they're getting connected to the venous network of the hand. So this is the whole section. I have missed at these parts. So from the very proximal part of the forearm, you can see this lesion going, continuing after the wrist. You can see it's still present at the dorsum of the hand region. So we try to measure it, how long it should be. It's more than 30 centimeter long. So this is a big arteriovenous malformation in this situation, having multiple feeding arteries and multiple draining veins. So it will be difficult for the clinician to definitely go for a treatment. So this is the arteriovenous malformation involving the posterior medial aspect of the left proximal forearm up to the dorsum of the hand. Make sure whenever you get a history of surgery, you always try to end the diagnosis or try to make the diagnosis as an arteriovenous malformation, because it's more commonly associated with the surgery. Okay, so after surgery, arteriovenous malformation gets very aggressive. Let's jump into the case number 3. Ooh, so today we have taken very big cases. Anyway, so this is a 50-year-old female patient who came with the left hypochondriac pain. This will be a very small case. Possibly from my last week. So left hypochondriac pain. Okay, so usually we think about some renal cause or some intestinal cause, but unfortunately this patient showed nothing of them. So here you can see the picture of the left kidney and the spleen. Now you can see the lesion. So this is the diaphragm. So this is the upper pole of the spleen, and this is the lower pole of the spleen. So here on the lower pole, you can see a cystic lesion here, but this cystic lesion is showing something inside. So whenever we see something inside a cystic lesion in liver, kidney, or spleen, we get some differentials. Okay, so let's jump into the next picture. So we have magnified it. Now you can see this cystic lesion is showing some thin septations inside. So whenever we say you a cystic lesion with internal thin septations, we commonly see you try to make it as a hydatid cyst. This case is not a hydatid cyst. You can easily go for an antigen antibody evaluation, or you can take a history of any attachment with the dogs and cats. This patient had nothing like that. Again, so this is a splenic cyst. This is an intrasplenic cyst with internal some thin septations. Usually, in case of hydatid cyst, if you look carefully, this is not a hydatid one. So if you see a hydatid cyst, if you look carefully, you will see 3 layers in the hydatid cyst. So the pericyst layer, that is the outer layer of the cyst, is usually hypoechoic. So whenever you get a cyst with a thin hypoechoic peripheral rim in liver or spleen, always try to make it a hydatid cyst. But this one is showing no pericyst here, so I don't want to go for that, and don't make it a very complicated. This is just a cyst with internal septations. These septations may be due to inflammatory process or due to hemorrhagic change, whatever. So this is a splenic lower polar cyst It's around 2 centimeter by 1.4 centimeter, but this is causing pain in this patient. So there is no other cause of pain for this patient, though it may be due to musculoskeletal also. So this is the cyst with internal septations. Okay, so this is a high frequency view, and we try to check the margin. And yeah, it is inside the spleen, and you can see this thin septations. So this is nothing but an intrasplenic cyst. It's a very easy finding. Okay, so let's jump into the case number 4. So this patient is of a 54-year and a male patient, obviously, because he came with a painful erection and there was a bending during erection. So this is a obviously erectile dysfunction case, and let's see what we have got on ultrasound. So it will be also a high frequency ultrasound evaluation. So this is the cross section of the penile shaft. During scanning, this is the corpora cavernosum, these two are the corpora cavernosum, and this is the corpora spongiosum. And during the scanning, you can see some calcified areas within the tunica albuginea at this part. This is a very big plaque. So this structure is, oh, this is multiple. You see, this is the first one. This goes the another one. It may be interconnected because before finishing one, you are getting another one. So these are the calcified plaques. Now the problem arises whenever you see this type of calcified plaque at the dorsal aspect. This is the dorsal aspect. You see the corpus cavernosa. So this area has the neurovascular bundle at this part. You'll see the deep arteries, the deep dorsal penile arteries at this portion if you put the Doppler. And below that, there will be a nerve passing through this area. So whenever the patient has this type of calcification at this part, they may compress the nerves at this point. So it will also make difficulty due to during erection procedure. So always try to say where the plaque is located. Now, if you end this diagnosis just looking at this plaque, you will be doomed. There should be something else also. So let's see the long section image. Whenever we are checking the long section, we found something else. Just let me freeze the image at this point. Now you see this structure. This is just, we are crossing from right to left, and at the mid part, there is a fibrous plaque here. In long section, it may look like it's within the corpus cavernosum, but no, this is actually the section of the tunica albuginea. So if you just go on the transverse section, you may find this also. So we have missed it on our previous section. So we need to search this one on the cross section. Now on cross section, if you look carefully due to calcification, you may miss it. Just go and grab this one maybe, or we just want to know this one not. So this is the calcified area. This is the calcified plaque. So we need to search this one. Where is that one? So you see, we are just moving the transducer. We are trying to see whether there is another plaque in longitudinal section. This is the longitudinal. Yeah, we saw this in this area. This is the calcified plaque. We have seen that. This is a big plaque here, obviously. Okay, now we want to see the that echogenic fibrous plaque. If it is not calcified, it should be counted as this one. So this should be the fibrous plaque. We want to see the location because it is showing at the mid part. Yeah, this one. You see this one. So let me freeze the image. Just go here, and yeah, this one is the fibrous plaque. In between these two corpora cavernosa, there should not be any triangular weight shape, whatever you say, any echogenic structure present. So this is definitely the fibrous plaque. In my country, I don't know why, this type of calcification of the tunica albuginea is much common nowadays. So I get at least 2 to 3 patients every week. I don't know why. So this is the transverse section. Now you can see we have seen that echogenic area. Yeah, this one. So this is the echogenic fibrous plaque. So here you can see due to the surrounding calcification, we have missed it previously. So This patient is having both calcified and fibrous plaques within the tunica albuginea, and together we call it a case of Peyronie disease. So here's another picture. Just we are trying to look for any other plaques present within this part. No. So here you can see, there is another calcified area here at the lateral aspect. We missed that. So you can see multiple calcified plaques within this, within the tunica albuginea. That is the margin of this part. So here's the largest one. It's the length on longitudinal section was around 1.7 centimeter, though ultrasound is not good for the actual measurement. So this is a case of Peyronie's disease. What we'll do for the treatment? Usually the prosthesis is the best option, I think. Many people do some laser procedures or something like that. But in our regular ultrasound practice, we don't see any satisfactory results. So if you search for the books, usually prosthesis is the best option, I think. But my clinicians know, obviously, better than me. Okay, so the last case of the day, this is the case number 5. Obviously, it should be the pregnancy case, and obviously it should be a large case. So this is a 19-year-old female patient who came with amenorrhea for 9 months. Okay, so this is not the time to detect the congenital abnormality. But the patient was sent to my center with some unusual appearance of the fetal head. They couldn't solve the fetal head abnormality, so they sent the patient to our center. So let's see what we have got on ultrasound. So here's the picture of the fetal head. Now, when you put the probe and you see this type of situation, what will be your finding? You have seen the ventricles here, but you can see a large cystic area. Now, is it the frontal aspect or is the posterior aspect? It will make you confused. So we need to solve it, obviously. So usually if you see the frontal cystic area, the frontal region, you try to make it as a hollow prosencephaly case, or it may be the interhemispheric cyst or arachnoid cyst. If you see it posteriorly, then you try to make it as an encephalocele, or if it is within the calvarium, then you try to make it as a case of posterior fossa cyst. So there are so many differentials, but we need to understand whether it's anterior or posterior. Let me show you, there will be so many videos for this case, so don't get worried. So let me show you this adjacent ventricles. You see the ventricles are very prominent. You may say dilated because you see this is the third ventricle. Let me freeze the image. So third ventricle is also dilated. So that means we have seen the lateral ventricles dilated, third ventricles dilated. Obviously, there should be a pressure over the fourth ventricle or at the cerebral aqueduct. So it's quite obvious. This is a large cystic lesion, so it can obviously compress the our cerebral aqueduct. But you see, this is the ventricle which is dilated here. So is it another ventricle which is dilated like this? I don't think so. So let's see so many videos so you can just differentiate. So we still don't know whether it's anterior or posterior. So, oh, yeah, we have found something. Let me freeze the image. Just go and back. You see this cystic structure? What is this? This is the orbit. So that means this is the frontal aspect or anterior aspect of the baby. So this should be the posterior aspect. That means this is the posterior fossa cyst, obviously. So whenever you see the large lesions, like in this patient, the cyst head was from this part of the abdomen, like from the entry-axillary line, like this area, crossing up to this part, like at the left mid-clavicular line. So huge sized head, like whole of the upper abdomen of the mother is covered by the fetal head or occupied by the fetal head. So this is crazy big head here. So huge size. Now, is this the brain matters which are getting compressed or whatever? So let's see it from different angle again. So we have found anterior posterior something like that. Now we want to go a little further. You see, these are the orbits or something, possibly. So we're checking the ventricles or the brain matter. Now, yeah, these are okay. You see two ventricles here. So this is the quite the facial region. So we can see the posterior fossa, large cystic area. Yeah, we have seen the orbits here. We'll see another video here. So let's go a little further. It looks quite hazy fluid here inside, obviously due to the machine setting or something like that. But it's the huge one. You can see this is the orbit. You see, this is the nose region. So definitely this is the frontal aspect of the baby. It's very small. Yeah, the face is very small in comparison with the whole of the back of the fetal head. This is the huge sized fetal head, like it's going backwards and backwards. So the huge large cystic space at the posterior aspect. So let's see it from another view, and now you still can see the cystic area, but we still don't know how it formed or what is the lesion. Here you can see the lesion. So let's look at this part. You see this structure? What is this? This is a leaf-like area here. You see this one? Let me freeze the image. This is the cerebellum. Is it normal? No, it's definitely not normal. Cerebellum should look like a W-shaped pattern. Like if I want to draw this cerebellum for this normal patient, so it should look like this. But unfortunately, it is not looking like that. So it is definitely a deformed cerebellum. So that is another important point. So we have found two findings, like a posterior fossa cyst and a deformed cerebellum. That should be enough for the diagnosis, but we want to look further. So let's jump into another view. You see the cerebellum now. We have decreased the gain. Now we are very careful about this area, and we want to focus at that part. So now we are checking it carefully. You see this cystic area. This is the cerebellum part of cerebellum. Now you see this cystic area is communicating. Here is the communication. This cystic area is communicating with this part. You see this cystic space. This is the fourth ventricle. So the cystic area is communicating with fourth ventricle. So definitely this hypoplastic or thin cerebellum with posterior fossa cyst and communication of the posterior fossa cyst with the fourth ventricle indicates this is a case of Dandy-Walker malformation. I have never seen this type of huge cystic dilatation of this part. So huge size cystic area. I searched for the whole spine to see any obstruction at that part, but the spine looks quite normal in this patient. Though the examination was not very satisfactory because the amniotic fluid index was around 8. So now you can see, just ignore my talks. Let's look at this view. Here you can see this. This is the, let me freeze the image. Yeah, you can see this communication here. This is the cerebellum, this plastic cerebellum. You can see the fourth ventricle is having communication with the cystic area. Fourth ventricle is also slightly dilated. So it's just compressing at the lower part actually. So, okay, so we have, we can end that. So this is the facial region now. And you can see this is the orbits. So this is the frontal aspect. You can see this is the third and fourth ventricle. And these are the dilated lateral ventricles, and this is the large cystic area at the posterior aspect, having communication with a dysplastic cerebellum. You see, this is the cerebellum. Now, the question arises, when I saw this case, this is 38 plus weeks of gestation, you know. So I asked the patient, have you gone through any abnormality scan or anomaly scan? Patient said that, yeah, I did that. Where's the papers? She didn't show me because if she try to show me, then I will copy paste that findings. She thinks that. So that's why she's not interested to show me. And don't, I said, I asked her, what was the finding? She said, I don't know anything. Okay, so I asked, is you are informed about any head abnormality? She said that, yeah, they say it's something abnormality going on. That's okay. She don't want to talk about that. So I don't want to inform her about the next one actually. So anyway, so I don't know why she was just waiting for this case since the 20 weeks of gestation when it was already been diagnosed. Okay, so here's the face region. I searched for the facial abnormality. There was no facial abnormality. Orbits look quite normal. And yeah, now the questionnaire is this situation making any bad prognostic condition to the patient? So you definitely should evaluate the renal system, and the cardiac evaluation is also recommended, because that will help you understand the situation of this patient. So we went for the cardiac evaluation also, so we'll show you that. So but still you can see these dilated areas. I'm just showing you from different angles. So this large cystic area, you see this is the dysplastic cerebellum having communication, putting some communication with the fourth and the cisterna magna. Okay, so this is the face. So this is the posterior fossa cyst, and this is the dysplastic cerebellum on the right image. And now you see this is the communicating part with the fourth ventricle. You see this is the communication, and this is the dysplastic cerebellum, and these are the dilated ventricle. So we measured. We couldn't measure the BPD in this patient because of the unavailability of the regular normal view. And obviously, we tried to measure a head circumference with our own interest. You see, the head circumference was 536 millimeters. This is a huge size head. Like, I have never seen a head like this before. So I don't know how they will deliver this case. Anyway, the abdominal circumference was quite lower than the our femoral length, though the measurements were not very accurate because the positioning of the baby was not very satisfactory, but still we tried to measure something. Okay, so let's look at the heart of the baby. If you look at the heart, in first view, it may look normal. It's a four-chamber view. It looks quite normal, but the orientation is okay. But if you look here, so this is a breech presentation baby. So in cross-section, clockwise, it should be the left. Clockwise, it should be the right side because it is a breech presentation. So this is the left side of the baby. The heart is obviously apex is directed towards the left, so it's quite normal. If you miss the orientation or site determination technique, just go to our website, our YouTube channel. You'll see our previous video about the fetal site determination, and you can get an idea how we can differentiate the right and left side in a baby. Okay, so it may look normal, but it is not normal. So if you look here, you see the heart is okay, but if you compare it with the thoracic cavity, the heart is actually more than 50% of this total thoracic area. So you just can draw a line from transversely and compare it. Yeah, the transversely, the heart is around 41 millimeter here, and the thoracic transverse diameter is around 59. This is the easiest way to say it as a cardiomegaly, though the actual ideal technique is to make the circumference and then you compare. Whatever you do, this is a cardiomegaly. So how it doesn't matter how you measure, it is the important to say it or prove it as a cardiomegaly. So that's up to you how you want to measure. So we check the heart rate. It was normal and it was regular. No, there is nothing irregular beats present. But if you look a little bit carefully, you should look at the ventricular walls. In this patient, the ventricular walls are quite prominent. So we think the heart is getting some thickening of the wall. So if you can make a follow-up, you will see there should be a development of the hypertrophy of the ventricular walls. Which is a common association with the cardiomegaly in this type of situations due to increased demand or something like that. So hypertrophic cardiomyopathy is a very common feature in these cases. Okay, so again, another finding, we want to solve another feature here. It's not clear, so let's look at another view. If we look at this part, there should be something fluid at the pericardial region. So pericardial effusion is another common finding, but we need to look it a little bit carefully. So just moving here and there, now you can see this is a pericardial effusion here. So very small amount of effusion. If you measure it, make sure you try to measure it, and it should be more than 2 millimeter to say it as a pericardial effusion, because sometimes you may make it a pseudo diagnosis or pseudo pericardial effusion. So it should be more than 2 millimeter fluid collection at the pericardial sac to say it as a pericardial effusion. Okay, so it was a pericardial effusion. Anyway, so this is a long case, and now you can see this is a 38 to 39 weeks of single live intrauterine pregnancy with breech presentation. We found some fetal congenital abnormalities. There was a large fetal head due to the posterior fossa cyst and dysplastic cerebellum, indicating a case of Dandy-Walker malformation with associated ventriculomegaly. So there was hypertrophic cardiomegaly or cardiomyopathy. Still, there is no arrhythmia present. So try to use these terms carefully. There is a minimal or mild pericardial effusion present. So we mention it because we want to inform the clinician that the heart condition is getting not better. So if you want to do further, you want to go for a Doppler evaluation, then you may see some other findings present. That's all. Thank you. Thank you for joining us. And our next session will be possibly on the 21 March Friday. Make sure if I don't have any iftar program on that day, then I can just take this session. So possibly there will be the session. So just look at the time schedule of which will be suitable for you from your country. So for the Singapore and China and Tokyo, the time is very much not suitable actually. Anyway, I have friends from Singapore and China, so and they'll be very angry with this time schedule. But it's due to the Ramadan schedule, and we have the prayer times, and we need to actually, it will be difficult to arrange before this time. So we have got a YouTube channel named Imaging Study. So if you find this channel helpful, don't forget to subscribe and share. Try to share our contents with your friends, because we get very poor amount of views actually. Yeah, so it will be appreciated if you can share our contents with your friends if you find this helpful. So anyway, thank you. We have a website named imagingstudy.com. We are very lazy to update this website. Don't know why. And thank you for joining us in this program. So that's all. So if you have any question, you can just ask, or we'll close it. Okay, so I have ended it within an hour. Thank you. Thank you. Okay, this video will be kept in our Facebook page. So if you find difficulty watching this in our Facebook page, you can get a better resolution view in YouTube. So we'll upload it in YouTube possibly on next day. So you can just go and grab it there. So just if you find this helpful, don't forget to share with your friends, obviously. So thank you for joining us. Hope to see you soon. And without you people, this type of arrangement, this type of program, or this type of session are useless. So you are the people who are actually appreciating this session. So we are also getting interested to arrange these ones. So thank you for joining us. Hope to see you soon in our next session on the 21 March. Till then, wish you all the best. Allah Hafiz.